Good afternoon to all the esteemed faculties. We have faculties from India. Very learned faculties from India, Dr. Shivkumar Sarin and Dr. Behra. And we have an interesting faculty from Philippines who is very much concerned about these issues. And on behalf of our Omni Curious platform, I extend a very warm welcome to you all, sir. Today, I'm thankful to you all personally, as well as on behalf of Omni Curious for sharing your time to discuss over a very important topic, the third wave of COVID. All of us know that third wave is on. About 1 week ago, we were debating whether third wave will come or not, when it will come. Today, the message from the world is third wave is on. From India also, third wave is on. Every day for the past 7 days, we are recording around 40,000 cases per day. And it is more common in 17 states, 2 of the southern states, and then other 15 in the other parts of the country. And the Union territories also. And United States of America, as all of us know, has recorded a maximum number of cases, 148% compared to the second wave. It has got the cases and it has gone up by at least 4 times. And as per yesterday's news, the beds are full. They are expecting that at any time they may run out of beds. And one important thing they have said is all the hospital admissions and those who are very seriously ill, 97% of them are not vaccinated. This is one point which will definitely add value for our discussion. China also now after Wuhan, it is experiencing a large number, around 27 cities they are, affected. Australia also there is a surge and there is again a lockdown. That is how both in India and globally, the numbers have gone up after the second wave. Therefore, we call it as a third wave. In many countries, second wave had a downfall and then third wave is come. In many other countries, the second wave was plateau and it has now gone into third wave. What experts call it as a merging of the second wave with the third wave. We are at this stage and we have lot of learnings from the second wave and we are getting every country, including India, is getting prepared to handle the third wave. Now at this meeting, we will try to discuss out. What are all the things that we need to analyze. Now shall I request Dr. Behra to discuss about what are all the learnings that we had in the second wave. We had no beds, we had no doctors, we had no remdesivir, we didn't have oxygen beds, and people were in ambulances for days together. People were in the reception, and there was a lot of mortality. I think we would like to hear to Dr. Behra about the learnings that we had, rather the experiences we had in the second wave. Over to Dr. Behra, sir.
Okay, thank you, sir, and a very good afternoon to all the esteemed faculty and our listeners. Sir, as you asked, when the coronavirus pandemic began early in 2020, experts wondered if there would be a wave of cases, a pattern usually seen in other virus epidemics. The overall pattern so far has been one of the increasing cases of COVID-19 with a surge in the summer and a large one in the fall. The months of April and May 2021, they have been extremely challenging for all of us. In the second wave, a very large numbers of patients were infected in a very short span of time. I think this is one very important lesson we learned. And then the medical facilities were overwhelmed, they're overburdened, and patients leading to scarcity of oxygen, COVID beds, intensive care units, then essential drugs and other resources. I think one of the very important issues which is not very often discussed is the lack of experts to handle the intensive care or the critical care needs of patients who require them. Besides taking care of the COVID and the non-COVID clinical work, The non-COVID clinical work also, sir, as you know, suffered a lot because all our attention was diverted for COVID, and COVID. So just to give an example, because I work in the field of TB control program, the TB diagnosis of our national program, it was down by about 30 to 40%. The case notification rate, this is just one example, and you can imagine about the other diseases. So this period was intensely focused on arranging more and more beds and oxygen for the COVID patients, delivering oxygen from liquid medical oxygen tanks, medical gas cylinders, oxygen concentrators, or splitting the central oxygen supply only as dire emergency measures. You have very rightly said about the vaccine. Of course, at that time, we are not ready, particularly our country was not ready with the vaccines, and that we are in a very primitive stage, let me put it that way. Then some follow those COVID precautions, particularly the COVID appropriate behaviors like physical distancing, hand washing, and mask wearing. So these things were obviously were not very strictly followed. So, the immunity and the vaccine, herd immunity that you have already told, and maybe we'll be discussing that. I think 3 or 4 important things which we learned, that if I summarize, obviously, I think we had lacked about the study of the epidemics. As we know, of course, it may not be appropriate to use the term Indian strain anymore, because many people take offensive and objection to that, because we knew that the strain was circulating even back as October 2020. But I think no precaution or nobody gave attention to that. So those double mutant, triple mutant strains, they came in. And then I think that we realized little late. Maybe that is one thing I should say. Then the second thing I should say about some of the unusual infections are about the black fungus, as you know, which is told very clearly, the mucormycosis that came up. The third issue is the, I should say, maybe I should dare to say, is a lack of coordination between the states and the centers. Actually, the blame gaming went on. Whose responsibility is it? I think unfortunately or fortunately, the health in this country, as per our constitution, is in the concurrent list. So always one can own it, or one can very easily disown it also. I think that game possibly went on for some time. So that lack of coordination, I should say, that we all saw very clearly, that also I think was one of the factors. So those are some of the lessons we learned: the lack of oxygen, lack of beds. Even the out of the numbers, sir, only, as we all know, it is only 10 to 15% of the cases who are either moderately severe or critical. Critical will be hardly less than 5%. But still we had we have to struggle with so many things. So I think with this, I will stop here, and maybe the others will add on. And if you ask me anything specific, I'll come into that. I just try to, touch upon certain important points.
Thank you, Dr. Begara. You have, summarized very well the learnings of the, second wave. We were really struggling for beds and, oxygen. You have highlighted it. More than that, you have talked about the mutants also. I think our Solent is going to talk more on that. We will leave that gap to him. Most important topic, agenda that you touched upon is the lack of coordination between the state governments and the central government. Actually, the World Bank made a statement. It is a failure of governance. Why the second wave was badly affecting, and people were suffering a lot for want of healthcare, people and so on. It is due to lack of governance. See, as you said, well, still health is a state subject. At least we want to make it as a concurrent subject. Dr. Sarin will agree with me that we have been fighting to make it at least a concurrent subject. like education and food. It is not happening in our nation, probably for, X, Y reasons. Surely this epidemic, there are many negatives. One of the positives I have put across is it has regulated the citizen to some extent. On the lifestyle diseases are coming down. I think Solent and Dr. Sharin will also agree on that. And secondly, governments have started coordinating. Though it may be a state subject or central subject or a concurrent subject, for the welfare of the people or health of the people, both of them should function as the two barrels of a gun. Thank you so much. Thank you so much. Now we will just go over to the mutants. I think when we were talking about, and Dr. Solenti was asking how is the mutant things that are going on. We know that for the second wave also and for the third wave also, the mutant strains are going to be, very important. And we will request our, Solente from Philippines to share his ideas on the value of mutants in causing the, epidemic and its clinical significance. Today we are talking about Delta, then it becomes a Delta plus double variant. Now today only WHO has said Delta is very fast in spreading transmission, whereas Delta plus it is little less in the transmission. We would like to hear from Dr. Ranjan Solenti. Over to you, sir.
Yeah, thank you for the invitation. Yeah, I totally agree with you that this third wave is driven by the Delta variant. And a lot of studies, initial studies was done and it has been found out that this Delta variant is 60 to 70% higher transmissibility compared to Alpha, Beta, and Gamma. And the expected transmissibility was also replicated in the viral load. When you look at the viral load of those infected with Delta variant, it's like 1,000 times higher than that of the original strain. And what is the implication of a high viral load? When you have a person carrying the Delta variant with a high viral load, that means when you cough, when you talk, you also spill out millions and millions of copies of this variant. And that's why the expected estimated reproduction number will also be very high. Comparing it with the previous variant, like the Alpha variant, it has been compared that a single individual can infect one individual can infect minimum of 4 to as high as 8. And because of the high viral load, it doesn't need to be more than 15 minutes interactions. In fact, there are anecdotal reports from Australia that even in seconds, for an individual who is not wearing a face mask and close contact, you can get the Delta variant in a few minutes. And that is what is now happening in the Philippines. For the past 3 to 4 days, our cases has increased exponentially, and half of the genomic surveillance report in the Philippines is now with Delta. Although our genomic surveillance is not as extensive as other countries, but we now have an idea that this virus is the one causing the increase in the cases. The other observation that I had with seeing patients in Manila, in the previous surge, like the second wave, we have a lot of these 60 years old and above, okay? But now, we now have more of this less than 60 years old. Younger population are infected, and more younger population as comparable as that of the 60 years old. And in fact, we have seen more cases now having severe COVID, even in the younger population. So the bottom line here is that the effect of this variant that mutated, which makes this virus more fit and more fast to replicate, okay, can be an important determinant why some younger population are getting infected and developing the more severe infection. And going back to the vaccine, I think the one very important intervention that can really mitigate and hopefully help us lower the cases will always be the vaccine, even though in some studies that there are reduced efficacy of this vaccine against the Delta variant. But in actual breakthrough infections so far in the Philippines who are getting vaccines, there are more people who are in the hospital without the vaccine compared to those who are vaccinated. Thank you.
Thank you. Thank you so much. I think we'll discuss further on the vaccines. You have another agenda when we come to the role of vaccines in the pandemic. Thank you so much for your observations. You have very rightly said the transmission is very quick, and even in a very shorter time of a contact, we will be able to get this, and younger people are getting infected. Now we are actually inside the third wave, as we have been discussing. Now there are a lot of studies how the third wave will come, how severe it will be. Lot of studies are there, like SIR study or SBA study. We will request Dr. Sarin to go into the facts of the third wave and how the studies have predicted, how the predictions have come, true. Sir, you have to unmute, sir.
Thank you so much for inviting me to this August gathering, and it's always a pleasure to have a session moderated and chaired by you.
Thank you, sir. Thank you.
The few issues before I come to some more facts is about the mutant virus. We screened in Delhi the whole of April, May, and June data. We have this large sequencing set up by the INSACOG, and 85% of the virus in April to June was Delta, 85.7%. The same time, those healthcare workers working at the Institute for Liver and Biliary Sciences who had received 2 dosages of vaccine had also got the Delta variant. Third, those who had single dose versus unvaccinated had more severe disease. 10% of the vaccinated, close to 30 to 40% of the unvaccinated. It means 4 times higher risk of unvaccinated getting the Delta variant. Delta variant also had gone down to the lungs faster in 1 to 3 days. However, the CT values, the viral loads were not different. This would have gone into NEJM, but because of slight thing, it is being tossed around now. So this was a data on healthcare workers in the Delta variant. We have found none of the Delta plus. Coming to the third wave, I think 3 things will determine the third wave. First, the development of new mutants. Second, our herd immunity, whether it is by vaccine or it is by our vaccination or by the herd immunity by transmission. And third will depend upon the free movement, how fast the people are mixing and not following. So free movement of unmasked or unprotected, our vaccination plus exposure, herd immunity, and the mutations. As of now, there are signs, and whenever there is a lull, like right now you think there is an ebb and there is a decrease in numbers, this is the time the virus also thinks he will die. This is the time the mutations will start developing, and you may have in next few weeks a mutant virus coming up. In my mind, there are so many studies and modeling and others, but none of them has fitted well into a prediction model because nobody knows the next mutant, how fast, if at all it comes, it will move. I have few thoughts in mind about which we may discuss again later, is about our involvement into a fact that has the second wave exposure given you immunity, or your vaccine non-response, or your vaccine's inadequate response. So let me touch those who have got earlier exposure can certainly get reinfected. Also, if they get reinfected, they can still have a severe disease with a mutant as if it is a new virus. Therefore, we need not put our guards down. The vaccine response, as reported by the Indian vaccines, ranges from 70 to 80%, both the Covaxin or the Covishield. So you still have non-response in a manner of 20%. And this response may wane over a period of time. So we need to be clear that, and we have no data today, unfortunately, of the need of mixed match or booster dose. And the third part remains of the unvaccinated large population. So if a third wave comes, which you rightly said, there is a fear, we are having a huge challenge. The US had in the second or so-called second or third wave, almost 4 million children involved with 16,000 hospital admissions in pediatric age below 12 and about 500-600 deaths in the children. We haven't seen that, but we should be aware that a pediatric population could get involved in this. Our preparedness, we will come to it, I'm sure, later, should include 3 or 4 things more. This must be known to the family physician. Our now contact is not a hospital. Our contact is a family physician. Now, what is the role of family physician? Comorbidity is bad. People know diabetes, people know hypertension, but all the data says that those who had fatty liver, this is the Hong Kong data, had more aggressive disease, the virus stayed longer. And India has nearly 25 to 30% of people with fatty liver. So since I work in liver, I have some more interest. I won't take more time, but one is family physician must see, oh, this guy is obese, this guy is diabetic, he has hypertension or fatty liver. Look, be more protected. Second, the vaccine responsiveness is less in those who have fatty liver. Third, our family physician has to handle and be ready with all kinds of toolkits. So the facts are, we haven't started seeing the third wave. Prediction models are still weak. Second wave is still surging in some areas. So we have a genome sequencing lab where we can do close to 400 samples, complete genome sequencing per week. I think we have to upscale genome sequencing to look for new mutant, even 1 or 2 mutants, and we are going to have it. So for third wave, our preparedness must include family physician. In fact, this is called lay epidemiology. Lay epidemiology is one where small group discussions are handled. It's not big national or city or state-wise. Lay epidemiology is a family physician plus 20 people. Family physician plus 20 people to educate people. This is the time of lay epidemiology, both for removing vaccine hesitancy as well as to guard them in the fatty liver or obesity or comorbidities and how to protect it. Thank you.
Thank you so much, sir, for the excellent exposition of the importance of a family physician. Today, entire health system is focusing on specialists and subspecialists. But family physician is the first contact. In my first communication to the government of India, I said, all the family physicians first be sensitized because they should know to recognize the disease. Because a 2 days fever, they only go to him. Or a nose block or a throat block, they go to him. Secondly, as rightly said by Professor Sarin, that they know the basic history of the patient. What are all the comorbidities here? He has a diabetes, hypertension, coronary disease, or a CA, or getting an immunosuppressant therapy for a joint. All these data are with him. Therefore, he has to be, sensitized, and he has to be utilized and put in the center of healthcare during this epidemic. You have nicely said, sir, about the mutants also. Your own experience in ILBS, you are really guided. I am sure we have subsequent discussions wherein if you are, you are always welcome to participate also. Now we go over to the preparedness for the third wave. Now third wave is there. We have almost felt it is secondly to the, lack of, the personal protections, all those things, and vaccine hesitancy and mutations, all the 3-4 points. Already Dr. Shivakumar Sarin has said. Now how India is getting prepared for the third wave, we will hear from Dr. Digambar Behera. Over to you,
Yes.
sir.
Yes, thank you, sir. I think very rightly, I think two veterans like yourself and Professor Sarin, I think you have highlighted. I'll just go a little further about, let me start with the physician training, sir, during even the first course, even during the second course, the chaos you saw, the so many drugs, so many regimen, somebody giving this, somebody giving that, it was really a chaos, everybody. So I think it is very, very essential that our physicians anticipating a third wave, because again, they are the, backbone of our healthcare management. So they should be trained. And I do not see, there are so many, webinars you can every day, every time you can see is going on. But I think that should be one focus. Very rightly said. And number two, sir, our medical, I think sometime in the second wave, what we have learned is that we have tried to utilize our medical students, particularly those who have gone into the clinical. Again, I don't see a great, type of sensitizing them. So that should start from the National Medical Council through them. I think they should be very active. I am sure it must be going on, or it is going on. So that will be another suggestion, particularly the people in the final year, students and others. There are so many PGs, it is all right, but every PG does not handle that. They need to be sensitized, they need to be taught. I think that sort of activity should be started in every medical institution who are handling or who are having this capacity. And obviously one more point I had forgotten to tell about the second wave, and I think Professor Sarin had very nicely covered that. That is about the application of the young persons or the pediatric age group. So I think that should be one focus for our preparedness for the third wave. And then the severity part I have already told. Now coming to exactly how we should be prepared, I think what happens next, India will need more strategic plans that we resist the second wave lockdowns. We should opening up the so-called COVID appropriate behavior, those three basic principles that should be emphasized. But I think it is more often said, or more often it is very, nice to speak actually in seminars or preaching it, but it is very difficult. We have to understand the human behavior, the social behavior of the persons. We go on telling, but I think it has to be emphasized. That is one of the very easily practiced, but it is very often not done. So we have to take into the social context, and we should involve more and more sociologists, why people should not use the mask, or why they are using the mask, why these things are happening. I think one social context needs to be added. Again, not diluting the importance of these COVID appropriate behavior. Then the vaccine thing, sir has already told that, yourself and Dr. Sarin said, we have to go on, come out of course, India has come out of that. So they have to have the plan how to get vaccine. So I am not going into that detail. Both it has both technical as well as administrative issues. So we have to see that vaccine is available, and the vaccine hesitancy that has to come up. And then the SCSM, this is a very basic principle in the field of whether it is communicable diseases or non-communicable diseases. That is advocacy, communication, and mass mobilization. That is what we call as the SCSM. So I think that should be very strictly emphasized, and that should be done. Just talking in the English TV news is not good enough, or just giving. I think that should come from the involving the society, involving the various ways. I think there are definite ways of SCSM activities. So maybe we'll be, doing something at that. Then obviously we should not lay down our guards, as we have already told. Then for the testing, the laboratories, and then the other issues that we should not declare the early victory, as has been done earlier by some people. That is not very easy. The second wave has taught us that it is far better to remain paranoid and cautious than be hopeful in a situation like this. And I think many people are telling yes, third wave is coming. So exactly, I am not very sure whether third wave is coming or not coming, but we should presume that it is coming. Sir, the WHO has given its very clear-cut guidelines about the strategies and the objectives in the form of its strategic preparedness and a response plan, what we call the SPRP 2021 as a 2022, which can take care of the third wave. The basic strategy should be suppress the transmission, then reduce the exposure, and then counter the misinformation and the disinformation, and then protect the vulnerable, and reduce the death and the illness, accelerate equitable access to new tools, including vaccines, diagnostics, and therapeutics. And they are based on 10 main pillars of coordination, planning, financing, and monitoring. I am sure this is the part of the government job. Then risk communication, community engagement, I think is very, very important. And then surveillance and epidemiological investigation, contact tracing and adjustment of public health and the social measures. Then points of entry, it is the social gathering, then restriction, travel, how it is to be done. And then of course, enhancing the laboratory and the diagnostics, including the genome sequencing and tracing the mutants. And that we should be very, very meticulous and strict about that. And then infection prevention and control measures and protecting the healthcare workers. That is also very, very essential. Then case management, clinical operations and therapeutics, then operational support and logistics and supply chains, and then strengthening the essential health services and systems, and of course, the strengthening the vaccination system. Sir, I think Professor Sarin, under his guidance, I'm sure the Delhi government is a advisor to the Delhi government, also to the government of India. So, I just came across a very nice plan of the Delhi government. I'm just giving that as an example. And I'm just quoting, of course, many state governments have done that. But I think this is one of the way I liked it, and I thought I'll just share it. That is the oxygen-related preparedness for the third wave. It is known, I think we have talked, all of us know that every hospital, everywhere, we should not have got that chaos because of oxygen. And I'm sure, I believe that now both the governments, whether it is central or the state governments, they are prepared enough now. Then the special task force for the third wave. You see, sir, during the second wave, what mistake was done? You see how many guidelines, every state, every association, central coming, DJs coming, AIMS coming, PGI coming, everybody, and that is not the way we should go, having hundreds of guidelines and then contradicting each other. Even a single wrong message is wrong. And I think this is the time where all of us, there should be a common message. There should be a guideline, should be for everybody. And of course, the task force preparedness in that includes the pediatric task force, which the Delhi government has done. Then the genome sequencing laboratory setup that has to be done. That is again a big mistake which the country had done. Of course, there are good, except how many centers are like this, which Dr. Sarin is heading. But I think we need many, not exactly to that standard, but at least something where the genome sequencing can be done. Then obviously the Delhi governments are what they have done. They are trying to build up 5,000 community health assistants to be trained so that they can take care of the mild cases. And then they have got a graded response action plan like amber, red, yellow, blue, like that. So I think that is when if a particular rate of infection comes, so this type of action taken. So I think these are the preparedness is already there, and at least they are in place. And I'm sure if the third wave comes, we will be better, equipped, and will be able to handle. That is what is my hope, sir. Thank you.
Thank you so much, sir. Dr. Sarin at Delhi and Dr. Shashank Joshi at Mumbai are the pillars as the task force for the government, and they have done an excellent job and needs appreciation. You have done it so well, and you have also, shown the light on the programs or the protocols given by WHO and Delhi, and almost the entire country now is conscious of all the failures they had in the second wave. They don't want to have it. It's so good. I'm sure with all these experts and the government getting more sensitization, we will have a better handling of the third wave, which we are getting into. Now we will have a discussion on the vaccines in this pandemic. There are any number of vaccines, all of us, nearly 72 are in the pipeline. But worldwide, we have got only 8 vaccines which are now commonly into use. Now we will hear from Dr. Solenti about the vaccines and the role of vaccines in controlling the pandemic. Over to Dr. Solenti.
Okay, thank you. Now, in the Philippines, we now have 8 vaccines that were given an emergency use authorization. And what are these vaccines? These are the mRNA vaccines, Pfizer and Moderna. Then we have the virus vector vaccines. That's the AstraZeneca. Then you have the Janssen and Sputnik. And then we also have 2 inactivated vaccines in the form of Sinovac and Sinopharm. And then just recently, Covaxin from Bharat, India, was also approved and given an EUA. And then the other vaccine that are coming, like Novavax is also coming. And hopefully we can have all of these vaccines in our country be given part of the rollout. Okay. Now, what's the importance of vaccines in the control of the pandemic? Okay, one is that they have good clinical data in terms of prevention of symptomatic COVID. Okay, and all of these vaccines that I have mentioned have underwent rigorous clinical development from phase 1, phase 2 to phase 3. So meaning they have been tested for safety, immunogenicity, and efficacy. Okay, and all of these vaccines have passed the threshold of the WHO in terms of prevention of symptomatic COVID, which is more than 50%. Now, why is prevention of symptomatic COVID very important? Okay, because in a pandemic, okay, you reduce the number of people that will become symptomatic, and that's precisely the objective of why people will not also be admitted in the hospital. The more effective the vaccine in preventing a symptomatic infection, the better for us to control the pandemic. You have vaccines like Pfizer and Moderna, which has a very high efficacy in terms of prevention of symptomatic COVID, as high as 90%. And in fact, in real world evidence, this has also been replicated. Where you have cases in Israel, in UK and US, there was a downtrend of the cases among those who were vaccinated compared to the non-vaccinated. In Asia, most of us are using the China-based vaccine, the Sinopharm, the Sinovac, and then we now have also these Pfizer and Moderna, and we're beginning to cope up and getting the vaccine to the most important vulnerable population. The second benefit of getting the vaccine is prevention of the severe form of COVID. In the Philippines, we have 4 priority population. 1, the healthcare workers. Why healthcare workers? Because healthcare workers are the ones high risk of getting the infection. So we prioritize the healthcare workers getting the vaccine. Second, we have the age 60 years and above. In the first wave and the second wave, our mortality for 60 years old and above was like 80%. That's too high. That's too much. Now with the vaccination, our current vaccination rate for this age group is still very low at 30%. There's still high vaccine hesitancy, but we continue to advocate. We continue to drive the message, the importance of getting the vaccine, because this will prevent them from getting the severe infection and from getting hospitalization. Third is the ability of this vaccine to prevent death. Okay, so in a way, if you prevent severe disease, you will also prevent death. Now, in most data that vaccines in prevention of death, there were data for Pfizer, for Moderna, for J&J, and Astra, where in most of this real-world evidence data in the prevention of death is like between 80 to 90%. So that's quite high, and that's the reason why we need the vaccine. Now, the fourth most important part of the vaccine is, the question is, how important vaccine can protect us against the variants of concern. Okay, and I think all of the experts here would agree with me that with Delta variant, most of these vaccines, its efficacy has been reduced based on neutralizing antibody. Okay? But there are data to somehow that this decrease in neutralizing antibody does not mean lower protection. Okay, like for example, with the Pfizer and Astra vaccine in UK, where most of the patients were Delta variant, it has been able to prevent hospitalization in more than 90% of the cases. Okay, in Israel, wherein the Pfizer vaccine was used, it prevents symptomatic COVID for those having the Delta in 63%. It has a lower efficacy, but again, it maintains its efficacy in the prevention of hospitalization. So more or less, if there is reduced in neutralization based on laboratory results, we haven't seen that yet in the actual rollout, wherein protection has been maintained, even the protection for death among this vulnerable population. But the most important question here is that how long will this vaccine work? 6 months, 9 months? Because there are already other countries now who are giving a third dose of this vaccine, like the United States. They just approved this day the third dose for those who have cancer or who are immunocompromised. But the question then that we are facing here in the Philippines, if we are going to follow and give a third dose, our vaccination rollout will also suffer because we still have very limited supply of vaccine, and yet a lot of people are not yet vaccinated, and yet we're giving a third dose to those who have already received the vaccine. So the group of experts here in the Philippines has decided that we won't deal much with the booster dose. We won't deal much with the third dose. Our priority is to vaccinate as many as we can with the current number of vaccination, the supply of vaccination, which is really to achieve what we call herd immunity. Now, herd immunity is very, very, very important for us to stop the pandemic, but we cannot achieve herd immunity with the way the vaccine supplies we have now, no? That's why we have this what we call population immunity, meaning we protect a certain population, higher risk of getting the severe infection, and we prioritize them for this vaccine so that our healthcare system will not also be overwhelmed by admissions because they will be protected by vaccines. Thank you.
Thank you, Solenti. Before I go over to the next session, can I put one question to you? There are nearly about 8 vaccines which is available with you in the world, in India too. Which of the vaccines you will prefer to your patients when it is available? It's a common question. Everybody asks me. Yeah. That's why I'm asking.
Yeah. I'll answer that question. Since I'm part of the government FDA also, and we are now listing the vaccines that will be ordered for next year. So top of the list there is the mRNA vaccines and the virus vector vaccines.
Okay. Any additions on that, Professor Sarin?
I agree with Dr. Solante. Only thing is availability.
Yes.
Otherwise, I think mRNA vaccines as of now look good. They can easily be made into newer ones, but the long-lasting effect of mRNA, we do not know. But it's a good choice.
In India, between the Covaxin and Covishield, which one you prefer, sir?
That's a commonly asked question.
Yes. That's why
I would say whichever you get first, you take it.
Whichever you get it.
And you take it.
Dr. Behera, you have anything to share?
Yes, sir. That is the same answer I give also.
Thank you.
Thank
you so much. We will go to the session on what is the role of healthcare persons, their services, their support, their recognition. There are a lot of displeasure among the healthcare people. They have done so much, they have sacrificed their lives. Without them, we cannot do that. In what way they should be utilized, rather what way they should be encouraged, in what way their services has to be supported in future also. Because that is a very important step in the handling of the, COVID cases, third wave. We are not sure whether we are going to go for a fourth wave. Because now USA, they're in the fourth wave. And even in Delhi, our Delhi CM has said that Delhi is in the fourth wave. Like that, it is going to come. And today, Dr. Anthony Fauci, the chief medical advisor to the president of USA, has said COVID will not go away. It will live with us, maybe in a smaller pocket. That is a statement today morning I listened to. Therefore, I would like to hear from Dr. Sarin on this aspect, sir. Over to you, sir.
Well, I think I may have a different view on COVID. COVID has brought the golden era of medicine.
Yes.
The golden era, how do you have a 24-karat gold? You have to be heated, you have to be beaten, and you have to be purified. The beaten part is we have taken the pressures, we have been purified of our so-called knowledge. We know that medicine has to be relearned every day. And the golden era is because we got the attention of the people. We got the attention of policy makers. So if the government could give so much of funding for health, making hospitals, ICU beds, creating posts, giving incentives, this is a golden era of the medicine. And in that way, if this continues and our infrastructure in health is upgraded everywhere, this is a golden era. And we should, at least I would pray that this continues, not because the COVID should go away, but the support of the people in government should continue. Now the healthcare providers also geared up. They have learned how to wash hands, they have learned how to wear masks, and they have taught the people. This was common sense. I will give you a small example which I think should highlight the importance. When I was a medical student, early 70s, my teacher was the one who developed Jaipur Foot, Dr. P.K. Sethi, who was one of the finest and strictest surgeons, and he was the chief of surgical unit. We all were working with him. But when he entered the ward, the nurse said, "Sir, you can't get in." And he was shocked. The ward nurse is telling me not to get in. "Sir, you haven't washed your hands." He told to the chief of the unit that you cannot enter this ward. And the message is still sounding, and the professor and head apologized. "I'm sorry, sister." He washed hands and then entered inside. So what I want to say is each one of us has to remember the importance of hygiene and importance of our duties to ourselves and to the patient. So that is one. Now the need of training and upgrading. I think there is an immense opportunity by the IT, by the telemedicine or teaching, of bringing out, like in the national program, what is required is people are upgraded in pediatric care, so the adults can do pediatric care if there is a need, and pediatricians can do maybe adult care. We also need to understand the limitations of the nurses. So I will briefly bullet out the points of what we should do, the healthcare workers. Everyone is an intensivist. All medical doctors, all healthcare professionals must learn intensive care. There is no substitute. Number two, be ready for innovations on the site. You may not get every time amphotericin, or you may not get every time a diagnostic facility. So please improve your clinical sense. Back to the basics of medicine. Three, please update your knowledge on a daily basis, not through the TV channels, but by reading. I would like people to know the side effects of drugs, excessive use of steroids, or excessive use of antibiotics, or excessive use of maybe immunity boosters by some people must be taken with great concern, and it should be knowledge-based. You should also, I would like, healthcare providers who are giving vaccines must ensure that vaccine adverse events are reported and not neglected. We need to also see that our emergency drug list is always filled. For example, you need steroids or you need anti-allergic or adrenaline or whatever is in your drug list. You should not say, look, I don't have this drug. No, essential drugs are essential. That's why the word essential is there. Through whatever recommendations, every state will now have a center of excellence for pediatrics. Every center in the rural area will have a bottom-up approach. All ASHA workers, all the peripheral workers are now going to monitor deliveries, pregnant mothers, so that if there is any infection in the mother or to the baby of COVID, it will be reported. The schools to be used as COVID care centers in villages. There has to be a involvement of the whole nation. So the preparedness is to the level of a school teacher who is converted into a healthcare worker. So a school teacher or a school is a ground for learning health and preparedness for that. We also have to learn to interact with each other. So the healthcare providers think, oh, I am a cardiologist, oh, I'm a liver guy, I don't need to ask anybody. But it shows our hollowness of knowledge. We need to learn and interact with all kinds of specialists. Long COVID, side effects of COVID, MIS-C or MIS-A have told us. I see so many patients who are coming, their diarrheas for months have not, settled after COVID. They have passing blood and they have got all tests done. I haven't seen all this in the past, that a diarrhea of viral origin persists. So we need to understand every day in new medicine. Few things more for the healthcare providers. We need to see, as Dr. Behra rightly said, our undergraduates, whether it is third year, second year, first year, they must be involved with the patients from the beginning. They must know. In fact, one of our recommendations had been that instead of a village posting, now you can do teleconsult sitting in third semester, fourth semester, little bit to the villages, little bit to the people. The pediatric guys should learn to interact with adults. So what I'm saying is the need of learning on job rather than learning from books has been re-emphasized for healthcare providers. For nurses, for healthcare technicians, it has been a huge challenge. Last part is no healthcare worker should be allowed to work. No healthcare provider should be allowed to work without a certificate of vaccination. If they have not taken 2 dosages of vaccination, they are not leaders in the society. They should be discouraged to work, take leave. So every healthcare worker must be involved and get vaccinated 2 dosages. Also, do not neglect chronic diseases like cancers or others. They are requiring more attention now than before. Also, one more thing, we all must be together in making medicine and healthcare providers more respectable. Do not accept any kind of trauma to yourself because of society. I would strongly urge, collect and say that what we do with dignity. We are doing with all our good intentions. If patient doesn't survive, that's not something we can manage. We can only provide the best care service. But of course, our standards have to be unquestionably good. But we are together in respect to our profession and our colleagues. I'm sure the same must be true in Philippines, and I would not cross boundaries on that, but would like support from every healthcare provider globally to say that, yes, we have done our best and we are the best.
Thank you so much, sir, for totally summarizing the need of the requirements of the healthcare workers to serve the community. You have done it so well with your vast experience. You have talked about the positives of corona, and in the era of subspecialists, he says, I am a cardiologist, I will only see heart. Today, you want everybody to learn about it and the involvement of the student and healthcare workers, you are nicely summarized, sir. We are, definitely thankful to you and indebted to you, sir. Now, before summarizing, 2-3 questions I'll just put forth, which are often faced by us. Number one is, you say that we will have to be vaccinated. We are vaccinating. Now, the ICMR Sero survey about 5 days ago has said 67.3% of the population are seropositive. Only another 30-40 crores have to be there. Now, you say again, after 2 doses of vaccination, you will have to wear a mask. When are we to walk without a mask? Now they say, the explanation I could find out is 2 doses of vaccination is given only for about 10 crore of people in India, though the number is about 58 crores. It is only given for 10 crores. Whether that is the reason or herd immunity has not come. What are your views, sir? All the 3 of you can give it. Let us start from Dr. Sari.
First, the Sero survey gives you IgG positivity in a sample to test cutoff ratio of 1:5. It does not give you neutralizing antibody levels, which are different. And neutralizing antibody levels are not known. Normally, the ratio should be IgG to be protective should be 1:640. Nobody is doing dilutional test. They are doing 1:80 as a standard. So a Sero survey is only a marker of exposure, not of immunity. 2, even if you are immune in a manner, if your antibody is 640, it is no guarantee that you will not get a variant. 3, if you have a symptomatic COVID, you have a higher chance of a higher antibody level. So I would say only those healthcare workers who had a symptomatic COVID can be slightly better off. Other than that, I would say vaccination is mandatory even after a COVID, both dosages. I'll give you a brief data. If those in which there was a Delta variant, the original vaccine, Covishield or Covaxin, would give you protection not more than 30 to 40%. You would remain vulnerable to another infection, not disease, but infection. Therefore, healthcare workers must wear a badge, I am vaccinated. At least the patient will have a confidence. This guy will not give me the virus. So remain yourself and give a safe doctor, a safe nurse to the patient.
Solente, your views on this? What's in your country going on?
Yeah, I totally agree with Professor Sarin. And in our country, yes, our vaccination take off in terms of the healthcare workers is almost 80% now. But there are still 20% that doesn't like to be given the vaccine. And I totally agree that we need to have that mandatory vaccination for healthcare workers. 1, because they should be protected. 2nd, they should not be carrying the virus and giving it to the patient. And 3rd, they should also be protecting their families. No? And I all of what Professor Sarin has stated, totally agree.
Thank you. Dr. Behra, you will have always something to share with us on this.
Yes, yes, sir. Professor Sarin, I think very rightly said, and I just can add one to that about the cross-reactivity about the other virus. So that part is not very clear. And then I think I will be told about even if you are vaccinated, why you want to wear a mask. Some people ask. I'll just give you one simile maybe. If you are driving a scooter, whether you drive it as a 20 kilometer or 60 kilometer, you have to wear a helmet. So I think that is what will be my take. Thank you, sir.
Good. Thank you. Thank you so much. And only 2 doubts about the vaccine. Now there are a lot of studies even in India. ICMR has come out with a statement that mixing and matching of the vaccines is good. Earlier we were thinking it is bad and dangerous. Now after incidental exchange of the vaccines in Patna and UP, it has done a study and comes out it is safe. Not only safe, immunologically more stronger. You get more antibodies. I'd like to hear the views of all the faculties. Again, we'll start from Dr. Sarin.
Well, it's not pure science to recommend mix and match.
Yes.
We have no evidence. 18 subjects is not
Yeah.
adequate. But yes, I would say booster dosages must be. And the country is far, far behind. We should have started it early January. We made this, but we have such strict rules. So today I cannot recommend mix and match. I would only say try it out. But I certainly recommend booster in patients or subjects who are non-responders.
Dr. Solente, you would like to add something on this?
Yeah, same here in the Philippines. We don't recommend yet the mixing of vaccine. For one, our supply of vaccine is really very low, so we cannot afford mixing it. We still follow the recommendation of a homologous vaccination, meaning the same platform vaccination. We are now trying to evaluate the importance of giving a booster or a third dose for healthcare workers only, okay? Because we have seen that breakthrough infections among healthcare workers, although not so common yet, but if you have 2 or 3 healthcare workers in a hospital that has breakthrough infection, you will isolate them for 14 days. Then that will be a challenge in the hospital. So that's still in a consideration, but as of now, we don't have yet recommendation of giving booster to healthcare workers.
Thank you. Dr. Baira, what is your
Yes.
view on this?
Yes, sir. I think I also agree with that. A small observation is not science. Maybe we can get away with this because if we are, suppose I have taken vaccine A and it is not available, I can always say, okay, take vaccine, it is all right. Take vaccine B, it is all right. And that may be the logic at this moment, but I don't think we should do that. We should not mix.
There are studies in UK also and Bangladesh also. They have also recommended. Now, incidentally, my third question has already been answered by Dr. Sarin. I wanted to, clarify whether a booster will you recommend. Now he has already recommended booster. Now China is recommending a booster. USA is recommending a booster. But my only, suggestion will be, rather request will be, which vaccine you will recommend as a booster? Whether they want to vaccine as the booster 3 or a new one as a messenger RNA vaccine.
Well, US has 7.6 dosages per individual and UK has 9+ dosages per individual, and we have not even one per individual. So we should not be talking of booster, but if you want to talk of science, I would not like another vaccine to be given as a booster right now till we have large set of data.
Large data, that's right.
Data. If at all, healthcare workers, same vaccine should be given as a booster.
Any other views from Solente or Begre? Thank you. Thank you so much. Thank you so much. Then we'll profusely thank all the 3 faculties. We have covered very well about the third wave. Whether third wave is on, yes, it is on. Why it has come, and due to vaccine that certain people have not had it. Even if you have it, it is effectiveness is only about 70 to 80%. Still some more is there. When it comes, what is the role of the healthcare people? How we should be prepared? What are the guidelines? And how the health profession, rather medical profession, should support? And we have, deliberated elaborately on vaccine, its efficiency, utility, and then which vaccine use, and about the boosters and mixing. All the things we have done as on date, we have made an analysis and passed on the scientific information to the participants. I'm sure this will definitely help us to keep the third wave under control and see that precious lives are saved. With profuse thanks to Professor Sarin, Dr. Solente and Dr. Begara, we will take leave and we will stay connected academically. Thank you.